Great. Thank you, Ryan. Beautiful. Well, as Matteo mentioned earlier, he is our presenter for the day, and he's going to be talking to us about acute and chronic pain in the setting of someone who has the concurrent diagnosis of opioid use disorder. So I will turn it over to you, Matteo.
Okay, thank you. Okay, well, opioid use disorders and pain. I actually meant to say opioid use disorder, but I think it's probably better to say opioid use disorders. We're finding now in the setting of chronic long-term opioid therapy, people that have been placed on opioids, that there's a new diagnosis that's coming to the forefront, which we won't talk about as much, but could be certainly another topic of complex opioid dependency. So kind of more of an iatrogenic situation in which folks are having difficulties with maybe tapering down to safer doses or ultimately off opioid medication. So I think it was a inadvertent mistake, but I think it's pertinent. So I'm over here at the Mountain Home VA. I've been here for 5 years. I am family medicine trained. And prior to now becoming full-time chronic pain in the complex pain management clinic, which is housed in the pain clinic, which also does interventions, prior to that, I was doing half-time family medicine and then half-time chronic pain up in St. Cloud, VA. And then prior to that, at an FQHC in New Mexico, where I did most of my training and was exposed to Project Echo and chronic pain. And so I was doing family medicine and was doing consults for complex chronic pain within that clinic. So I have a number of years of experience with chronic pain, and then now with addiction medicine board certification as well. Okay, so I don't have anything to disclose other than being a federal employee. I have to disclose that these slides are my personal opinions and ideas and do not reflect those of the federal government. Many of my slides were adapted from 2 of my mentors, as well as PCSSnow.org, which I'll explain in a second. So special thanks to AJ Monhapra. He is an amazing physician. He's an educator as well at Yale School of Medicine. And he works at the Hampton VA as well. And then additionally, Dr. Bott, who's a psychiatrist, addiction psychiatrist who works in the pain clinic there as well. And he's with Project Echo. Project Echo, I will just put a plug in as we're obviously affiliated and using this model. It is an amazing model, and it is how I've acquired much of my both pain and addiction practices. I believe in the model and have been involved in it since probably 2006. And so, they're doing amazing things. And I would say, just put a plug in, they're having a really good series about COVID-19 as well to get extra information about that. PCSSnow.org is a national training and clinical mentoring program. You can use as much or as little as you want. There is a really good clinical mentoring program, but primarily I've used it for the pain core curriculum as well as addiction webinars. And so there's a slew of offerings, free CMEs online, and there is also MAT waiver training as well. So my objectives today is, to describe an evolving chronic pain paradigm. So, much of the first part of my talk is just going to be talking about just comprehensive pain management, really in any setting. And then we'll get into specifics of treating chronic pain in OUD, but they're often very similar. There are some nuances when someone is on medications for OUD, which is our last objective, just describe specific strategies to manage acute and chronic pain in these patients with medications for opioid use disorder. So this new pain model, this is the conventional pain model that I will admit that I'm still trying to kind of get out of. It's a difficult one to get out of. But essentially what we're saying is that acute pain and chronic pain are very analogous. And that's a problematic model. So the first part of the slide, the acute injury, ultimately leading to a pain signal that's sensed in the brain. You know, a lot of times patients accuse us of saying that the pain is all in their head. Well, in large part, it is in their head in the sense that it's sensed in the brain. And many of these brain centers that sense pain are very integrally linked to the limbic centers, which then create not only you know, the physical pain in the kind of sensory centers, but also kind of distress and suffering in the limbic centers. And there's, you know, communication between the two. So ultimately leading to distress that ends up leading to physical disability and kind of this vicious cycle. Now, chronic pain is thought originally to believe that, you know, there's this injury and that there's ongoing injury and that there's really not substantial healing going on, and you're getting this signal because of this ongoing persistent injury. We still kind of have the sensation and then the distress and disability that results from that signal. So more of what we're seeing in the new pain model is that this signal is aberrant. So after 3 to 6 months, now the pain kind of chronification of pain, and that ultimately leads to certain types of behaviors and healing responses that are often maladaptive. And additionally, the thought is that these signals that we're getting from what we call these pain generators are not necessarily because of ongoing, you know, noxious stimuli. The noxious stimuli or the injury is pretty much as well healed as possible, and that now there's actually changes in the brain pathways, both peripherally and in the central nervous system, that now is almost, it takes a life of its own, and then takes a life of its own with respect to pain behaviors that are maladaptive. And so it's this idea that many factors kind of ultimately lead us into the final sensory experience of pain. Psychosocial factors, comorbid medical problems, psychiatric disorders, dependencies, and then iatrogenically the polypharmacy that can actually lead to substantial problems. So really the challenge here is to kind of think that it's actually not necessarily this noxious stimuli that is this ongoing problem in the creation of chronic pain. Again, difficult. You know, I saw a guy yesterday on telehealth, 75-year-old guy with a, you know, horrible tricompartmental disease in his right knee, 300 plus pounds, 370 plus pounds. And, you know, he's seeing his orthopedic physician who says he won't do a total knee arthroplasty until he loses 100 pounds, but he can't really engage in any substantial weight loss because he really can't move around. And so, you know, there's a pain generator, there's, you know, a fairly substantial disease. And so it's hard not to say that this is ongoing injury. And, you know, ways in which we're going to approach it would be to kind of stop that signal. But I still think that the new paradigm is this idea that the signal is aberrant and it's not necessarily from ongoing injury. And we'll go into how we might treat him later on. Just again, kind of this idea of how the chronification of pain ultimately leads to maladaptive behaviors, the stress, catastrophization, which is a term that might be falling out of favor, that leads to, you know, worsening mental health conditions and possibly the development of dependency and opioid use disorder. So the new paradigm really focuses on a biopsychosocial approach, so body, mind, spirit, in ways to really not necessarily decrease that pain score. You know, that pain score got us into problems in the early 2000s, end of the 90s, into kind of overutilization of opioids and treating that score to get it down, to get in those improved Press-Ganey scores. So now we're really kind of focusing more on attempts to increase function, and then, you know, ideally also decrease suffering. And really the mainstays of the chronic pain management would be to first start with self-management. What can the patient do for themselves to really affect change in the function and suffering? And then additionally, we use non-pharmacologic measures as well as pharmacologic modalities, which we'll get into briefly. So self-management starts with the patient moving. Movement is key. It doesn't have to be an extreme amount of movement, and certainly, it's important to teach patients strategies in which they're pacing. But the overall goal with this movement can actually decrease overall inflammation. Certainly, weight loss can help with that inflammatory burden reduction, and certainly decreased weight bears less, weight on weight-bearing joints, and so we're kind of decreasing some of the pain that can come from those joints. Ideally, lengthening muscles and strengthening muscles are important in self-management. And then smoking cessation is actually what I believe a form of chronic pain management, because the smoking cessation, smoking certainly increases that inflammatory burden that someone has, making these pain signals and this aberrant signal more prominent. So the non-pharmacologic measures that we often employ would be acupuncture. We're doing various types of acupuncture. I'm not so sure you all can see, but I had some battlefield acupuncture placed to my left ear. These are little tacks that are placed, barbed needles. They're actually pretty painful going in, but they stay in for about a week and they stimulate certain points. And, I'm not entirely sure of the theory, certainly kind of working more on the meridian and energetic body, for lack of a better term. And so, kind of hopefully modulating some of the signals, and then ultimately, again, decreasing some of the pain, increasing the function, and decreasing some of the suffering. I have to say I was pretty focused yesterday after getting them applied. I'm not sure if it was placebo or not, but I feel pretty good. Chiropractic care is another one that we refer to. Myofascial trigger point release is my favorite, near and dear to me. I believe a lot of people suffer from trigger point myofascial pain syndrome. And there's a number of different ways to deactivate these muscle knots, either manually, needling with dry needling, and then trigger point injection. I'm a little biased to pain psychology. I'm actually married to a pain psychologist. She's not working here at the VA, but certainly we have a really good pain psychologist here. And I believe that that's kind of the foundation of a good pain program. Working with CBT, cognitive behavioral therapy, ACT, acceptance commitment therapy, and then working on pain coping strategies. And all this, again, to kind of increase function and decrease the suffering that goes along with chronic pain. We have a really good physical therapy program, kind of looking at a neurophysiologic kind of basis, again, these aberrant signals, and working to develop home exercise programs, keeping in mind the pacing strategies. And then, of course, we do have the advanced interventional procedures that go after those pain generators and try to calm things down. These are not fixes. These are not long-term fixes. And typically, we can get a period of time in which we get some relief. And really what we're trying to do is create a window in which someone can now implement some of these self-management strategies and movement strategies, so that they can now kind of take the reins and hopefully live a more functional life. So these include epidural shots, facet blocks, radio frequency ablation of the median nerves, and dorsal column stimulation. The gentleman that I spoke of earlier with the right knee, advanced osteoarthritis, what we would do for him would be what's called a genicular block. And so what happens is there's 4 areas of the knee that are anesthetized, and that's under ultrasound guidance. And thereafter, if there's a good response and reduction in pain for 8 to 24 hours, then we would move on to actually ablating those nerves with radiofrequency ablation. And typically, you can buy someone a year, possibly, in avoiding total knee arthroplasty. So we're hoping that could bridge him to losing weight. So the pharmacologic non-opioid measures are tricyclic antidepressants. These are typically low dose. I typically dose them at night, hopefully help with some sleep. We do have to be careful in the elderly. with certain QT prolongation and uh, the next group is the SNRIs. So we're talking duloxetine, venlafaxine, milnacipran. These are typically effective, and they can actually be effective for neuropathic pain as well as musculoskeletal pain. We do have to be careful in certain circumstances with hepatic disease with duloxetine, and typically the main point in using these is you have to get up to a fairly high dose. When you're dosing SNRIs at lower doses, they function as an SSRI, more of the serotonin reuptake inhibition. Whereas if you get up to the higher doses, like above 60 for the duloxetine, 225 for venlafaxine, then we're now getting into more of the norepinephrine modulation. And it's thought that the norepinephrine modulation is involved more with pain. And this is both ascending and descending pain signals. So not only are we getting ascending signals to the brain, we're also getting inhibitory modulatory signals that come down from the brain and can influence the signals going up. Of course, we have the NSAIDs. I typically try to use topical over oral. Oral NSAIDs have many risks, including cardiovascular and renal, not to mention the GI upset that everybody knows about with increased risk of bleeding in the GI system. So diclofenac gel just recently went over the counter, and these can be helpful applying 4 times a day to affected areas. Gabapentinoids are helpful primarily in the setting of neuropathic pain, though there can be some other kind of central pain syndromes that can be affected. We do have to be careful of the renal dosing on these medications, but typically well tolerated. In the addiction setting, we do have to be careful. There is abuse potential for gabapentinoids. I think sometimes maybe kind of overstretched. I do feel like that they're helpful and can certainly be beneficial in a lot of circumstances. Capsaicin is a medication that's a topical medication that actually depletes substance P, which is a pain generator often found in the transmission of neuropathic pain. Tough part about this one is that it's derived from a chili pepper and can be quite cumbersome to apply and painful to apply. But the idea is that after 2 weeks, 4 times a day to the affected area, you have now depleted that substance P and you've kind of jammed that signal such that you're now getting less of that aberrant signal. Muscle relaxers are, I think, used too often and too long term. I've seen some veterans 20 plus years of Flexeril, and it's not a good idea. These are for short-term use and really looking at using for kind of pain exacerbations. Okay, so the opioids, CDC, as everyone knows, came out with guidelines for primary care physicians, and VA also, VA DOD came out with guidelines. And really, the idea is that it's not to say that we can't use opioids. I think a lot of people misinterpreted the guidelines. You can certainly use opioids, but we need to be much more responsible in how we're prescribing them and really see that they're kind of the last stop on the pain continuum as far as pharmacologic measures of management. And we really need to think about the risk-benefit analysis. And oftentimes with comorbidities such as, obesity, sleep apnea, concurrent, suicidal ideation, these medications often do not have a great risk-benefit analysis, and I argue often shouldn't be used. Again, we've got to focus on that function and not the pain score. Opioids are affecting analgesia both centrally and peripherally with the mu-opioid receptor primarily, and also affecting the limbic brain and reward centers. And this is thought where we're probably affecting the suffering. And so, you could argue that decreasing suffering is certainly part of treating pain, but with that comes the concomitant risks of addiction. And dependencies and use disorder development. Typically what we say is, try to stay under 90 morphine equivalents. So morphine milligram equivalents, there's various calculators. University of Washington has a good one, but typically there's a pretty good calculation, and you want to stay pretty much 90 is kind of what I feel is a pretty good ceiling. And if people are above that, ideally trying to get them down, especially if they have comorbidities. There's seems to be a risk escalation after 50 morphine equivalents daily dose. And then after that, we see another step up of adverse outcomes after 90. So now getting into chronic pain and OUD. Various studies have shown that patients with opioid use disorder have between anywhere from 37 to 64%. I think it's a pretty common concomitant finding. I would say it's probably somewhere there in the middle, and certainly we need to think that we need to address chronic pain when it comes up in OUD, right? Because it can be a trigger, and we'll get into that in a little bit. So it's bidirectional. So I mean, it's not always it's the chicken or the egg, but 39.8% often had pain first, and then they subsequently developed OUD. And whether that's iatrogenic or illicitly treating their pain on their own, that's unclear. But certainly, a lot of people we can help. We have helped them along in getting there, and so clearly we need to help them once they develop OUD with medications and psychosocial interventions. But in this study of 5,000 individuals, 35.6% didn't have pain prior to OUD. 99.7% had OUD first and then developed chronic pain, and then 14.9% had both concurrent OUD and pain at presentation. But the largest portion had the pain first. Many patients with chronic pain have had high rates of mental health disorders, as we often see, and that the OUD before the onset of pain were likely to have SUD diagnoses as well as HIV and hepatitis C. So the management of chronic pain in OUD really should mirror what I went about in my first part of my talk, comprehensive pain management, biopsychosocial approach. But the fact that, we really need to address chronic pain, given its preponderance and burden in the patients with OUD, certainly can be a trigger for return to use of illicit drugs. And so, like I said, this comprehensive pain management strategy is the best one. And we'll go over, kind of ways in which we can use medications that we're giving for OUD and adapt them more to maybe facilitate some of the reduction in pain with these medications. And I'll go over that a little bit more. But basically, the idea for the agonist and mixed agonist therapies, we can adjust the dosing strategies. So for acute pain, this is kind of a conundrum. If certainly, kind of the idea of this slide is that, there's a lot of fear by physicians, both addiction and non-addiction providers, that we are going to worsen the OUD if we treat pain. And again, there's many ways to treat pain, but if the pain is severe enough, a mu opioid agonist might be called for. And so we need to decrease our fear about treating that pain, and that treatment of pain leads to actually less risk of furthering the OUD by decreasing the cravings and the risk that might come up in this acute setting. So kind of older studies in the setting of methadone maintenance program showing that opioid analgesia for acute pain did not increase the chances and increase risk of relapse. So the most difficult situation in which acute pain management comes up in the setting of MOUD would be the use of naltrexone. I don't really, I do believe that, naltrexone is a second and third line option for OUD, and I'm concerned because of when these situations arise. So, if there's an acute situation in which pain management is needed, you certainly stop the injection, you stop the oral administration of naltrexone, and obviously we know that naltrexone is blocking the mu opioid receptor such that it would not be open to modulation by the agonist. Now, this isn't totally true. You can dose fentanyl to levels that you can overcome that blockade and inhibition, but that's tricky and really needs to be done by anesthesia in a monitored inpatient setting. And so, in these settings, we certainly want to optimize non-opioid management. And again, our friends with anesthesia will often employ intrathecal pumps, catheters, regional anesthesia techniques, and then possibly all the way to ketamine and lidocaine infusions. Naltrexone has a variable washout period, so this can be, again, tricky to kind of maintain and watch, and can be a dynamic situation. And interesting, patients really should carry an alert card or bracelet, designating that they're on the injectable. I should say naltrexone, not naloxone. So acute pain management in the setting of agonists and mixed agonists is easier to do. With respect to mild to moderate acute pain, methadone may be increased. Methadone has an analgesic effect of typically 6 to 8 hours. So typically what we would do is see patients take their medications, their daily dose divided TID to QID, so 3 to 4 times a day. And equally, buprenorphine can be done the same way. And buprenorphine typically has this 6 to 8 hour analgesia. As we know, in the treatment of solely MOUD, that is a once a day dosing, typically for both medications. Some patients like to break them up throughout the day just for simple run-of-the-mill MOUD, but I do like to break it up throughout the day for pain issues, including acute pain. Now, you can add full mu agonists to either of these regimens, but we will see that they often will need higher doses of agonists rather than your typical doses for someone who's maybe naive to opioids. And this is true in the setting of a chronic pain management on opioids. They typically will need higher doses in acute settings. Ideally, again, we're using non-opioid management if we can, some of the other adjunctive medications. And remember, like we said, treating the baseline addiction doesn't typically, at least if it's not dosed 3 times a day, it does not treat this acute pain and will require some other likely intervention. Special note about methadone, as we know, it's not reported to the CSMD or to the databases. So if a patient requires inpatient admission and we can't maybe after hours get that dose, it's important to dose not all at once. We're going to break it up anyway and kind of see how the patient responds to the dosing and then titrate from there as needed. Again, you can add a short-acting opioid for breakthrough as needed. And methadone is commonly used, although less so, and really more in the setting of a complex pain management certified physician. And methadone can be quite helpful in many pain conditions, and that is dosed at least BID to TID, as opposed to the addiction dose of once a day. At discharge, it's important to give patients a last dose letter so that they can take that to their opioid treatment program so that there's good communication and when they reestablish with their opioid treatment program. So if there's an anticipated need for pain management, say in the setting of upcoming surgery, the old way used to be that surgeons would like the addictionologist or the provider, to taper the buprenorphine and then ultimately transition over to a full mu opioid agonist after post-operatively and treat the pain that way. And then ultimately maybe taper that post-operatively if sufficiently recovered, then moving back over to buprenorphine. I don't really suggest this way. I find it risky in the sense that that tapering of the buprenorphine can put us at risk for return to use. And so the way that I think is gaining more favor is to continue with the buprenorphine dosing, changing the frequency if we need to, potentially increasing that dose. And I find that that's often enough and doesn't require the addition of a full mu agonist. Buprenorphine is a good pain modulator, but often does require these dosing changes and augmentation of dose potentially. But if there is an anticipated condition in which the pain is going to be severe, maybe in a palliative or hospice setting, there is the idea that maybe transitioning over to methadone, which is a full mu agonist, would be a better option. Because there's not this ceiling kind of effect that we see with buprenorphine, and so you can titrate further, and so in some circumstances that that would be done. It's pretty easy to transition over to a full mu agonist that way with methadone. In the setting of methadone, again, we already talked about, split dosing, TID dosing can increase it, and then you can add the mu agonist as needed. So I guess some of my final thoughts before the conclusion would be this complex opioid dependency, again, kind of in the setting of a long-term opioid therapy in someone that's really had difficulty with reduction in dose, and maybe that reduction in dose is initiated due to concerns about safety with comorbidities, or maybe there would be some potential developing aberrancies, and maybe developing either mild or eventually moderate opioid use disorder. And so in this gray area, we are finding that transitioning over to buprenorphine is a good management technique. It decreases the overall risk for overdose and death. And we're finding that across the country that a lot of people are starting to now use buprenorphine in that setting. So there's certainly more to come in that. So in conclusion, I want to reiterate that there's this new paradigm in viewing the pain physiology, that it's not just this area of ongoing injury, and that there's this aberrant physiologic neurologic transmission, both peripherally and centrally, and that we're really trying to kind of modulate that through various interventions, both non-pharmacologic and pharmacologic. Chronic pain is very common in OUD, and we really need to employ this comprehensive biopsychosocial approach. Opioids are the last kind of resort in chronic pain, but can be used. It's not an absolute contraindication. Agonist therapy is often adjusted both in acute and chronic pain settings, and can be done fairly safely. Full mu agonists can be added to these regimens, and then careful with naltrexone and getting your anesthesia colleagues early in the management, because those can be quite difficult to manage. And with that, I will give it back over to Dr. Troxler.
Mateo, that was awesome. Thank you so much for that rundown. It was fabulous. It's a really thorough rundown. I appreciate you doing that for us today. Did anybody have any quick questions for Mateo's presentation? Because we've got a case to present as well. So any comments?
I have a quick question. What kind of cognitive behavior therapy do you use when you use that? Is there a certain program of that you use? I know the moral recognition therapy is a cognitive behavior therapy. Is there what do you use?
I can't comment on specific protocols. The VA does have a CBT specifically developed for pain, and it has been in use for many years. I can't comment exactly on the techniques or strategies used. I'm a medical doctor, and so I'm more of a cheerleader. I probably don't use too much CBT in my practice, but certainly refer a lot over to her. So can't comment on specific techniques.
So I think it's generally just, it's like an umbrella term of there's a lot of different options for protocols that are effective, but it's that kind of general idea of changing beliefs, behaviors, emotions works. And the evidence base, I think they've done trials with a couple different types of protocols and found it to be effective. So it's pretty wide reaching. If you're doing CBT, it's probably going to work.
CBT. It will work. Awesome. We do have a case and we have it typed up. I can go into my email and pull it up, but I didn't